We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.
How did COVID-19 take so many Ontario seniors living in long-term care during this pandemic? That's our question for this hour. First up, health columnist and author André Picard is here on his new book, Neglected No More, examining how Canada cares for its seniors. Spoiler alert, not well. Then, what part do policy, profit, and oversight play in what's unfolded in facilities and care homes across the province? It's Wednesday, March the 3rd, and that's next on the agenda. Well, more than half of all the COVID-19 deaths recorded in this province took place in long-term care settings. And many more seniors are still living in isolation and fear, hardly what anyone wants for them in their final years. André Picard is a health reporter and columnist for the Globe and Mail. He's been watching the difficulties in this sector since well before the pandemic descended, and he details it in his new book. It's called Neglected No More: The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. And André Picard joins us now from Vancouver, British Columbia, and it's great to have, for my money, the best health columnist in the country on our program again. André, how you doing?
Good, thank you.
Glad to have you with us. I'm going to read a paragraph from your book that sets this up in very dramatic form. Elder care in this country, you write, is so disorganized and so poorly regulated, the staffing so inadequate, the infrastructure so outdated, the accountability so non-existent, and ageism so rampant, there seems to be no limit to what care homes can get away with. This is a very blunt and stinging indictment about what's going on. And as we learn in the acknowledgments in the back, it is no academic discussion for you. Your parents ran into this situation. What was your family's experience? Let's start there, André.
Well, my family's experience was like that of millions of Canadians, sort of this inevitable journey from being well to retirement, to chronic illness, to going to a senior's home, to going to a long-term care facility. And then, you know, the care being kind of overpriced, mediocre, frustrating to navigate. And then we have something like a pandemic come along, and it just really shines a light on all these problems that have existed for a long, long time. And finally, we're paying attention to them.
Well, since you mentioned the pandemic, let's go there. And I want to take you back to basically about exactly a year ago. We are starting to hear about this thing, and it's making its way around the globe. And I wonder, at that time, what alarm bells should have been going off in the long-term care sector that clearly did not?
Well, I think we clearly should have raised the ramparts very early. I wrote a column before the first death in long-term care saying, listen, long-term care facilities are vulnerable. Look at what's happening elsewhere. All the people dying early in the pandemic in China, in Italy, in Spain, where there were the first huge outbreaks, they were all elders, and a lot of them were in care homes. All the messaging was there. All we had to do was listen to prevent this horror that's taken place subsequently.
And why did the bells not go off, and why did they not do anything about it?
Well, I think a couple of reasons. One is we are very influenced by the history of SARS in Canada. So SARS was quite devastating in 2003. It was very much a hospital-based infection. So this time around, our hospitals were actually very well prepared. We haven't had big problems in our hospitals, but we forgot about these other homes, the nursing homes, the long-term care facilities, seniors' residences. They're not officially part of the health system. We just left them off to the side, even though we knew theoretically they were at risk. They just don't have anyone in charge. They don't have anyone speaking up for them.
I want to amplify that last point you just made, because I've heard this from so many people who work in and around healthcare, that long-term care is, in spite of its title, is not really considered part of the healthcare system, and in fact is kind of that poor second cousin that you stick at the end of the table that you don't really want to have anything to do with at Thanksgiving. How did that come to be?
Well, I think it came to be through our history. The long-term care system has its origins not in healthcare, but in the prison system, in the penal system. We had until 1961 in Ontario, we still had punitive measures in care homes. You could be put in solitary confinement. You had to work for your meals, etc. So this is in my lifetime. So this is not an old thing. We're really bound by our history. And then we have Medicare, which is in Canada, as you know, very much we pay 100% of physician care and hospital care, and everything else is kind of cast to the side, and some things are cast further aside, one of them being long-term care. It's sort of take our elders when they get old and rickety, and out of sight, out of mind, we put them in these institutions.
All right, let's get back on the path and continue to tell the story then of a year ago. When it became apparent that long-term care homes had a problem, how quickly, how expertly, how effectively did the staff in those homes and the people who run those homes respond?
Well, the response was very slow, was labored, and to be fair, the staff just didn't, it wasn't a fair fight. They didn't have personal protective equipment. Staffing is inadequate. The conditions, the infrastructure is such that it was very difficult to protect elders. When you have 3-4 people with chronic illnesses sharing a room and a new virus comes along, they're really sitting ducks. So all the elements were there. It was a perfect storm for the spread of illness. And if we step back, we have to remember that every year in these homes, thousands of people die of the flu, of food poisoning, of all kinds of infectious diseases. These are like cruise ships on land without the fancy buffets. So all the elements are there for the spread of illness. And when a new virus comes along, we have seen just how devastating it can be.
I wonder if part of it as well was the fact that, and again, I heard this numerous times as well, you know, these are frail elderly people in their late 80s. What do you expect? That's what we heard. Now, what kind of attitude is that to take to this?
Well, we do have that attitude, this ageist attitude that old people are disposable, that, I can't tell you how many times I heard, they were going to die anyhow. And I think we have to combat that myth. It's not true. It's true that everyone's going to die eventually, including us. But the numbers of deaths that occurred, there have been 22,000 COVID-19 deaths in Canada. 16,000 of those have been in care homes. This is overwhelmingly attacking this demographic. And you take your average home has about 3 or 4 deaths a month in 200. These homes had 50, some homes had 100 deaths in a month. There's nothing normal about that.
Well, if you needed any more evidence that the arc of this story was deeply disturbing, I mean, they sent the Canadian Forces in to some of these homes to help them out. That's how bad things were. How significant did you think that was in the arc of this story?
I think it was a very, very important moment symbolically. I think it really struck home to Canadians just how dire the situation was when we saw the soldiers go in. For me, it's unfortunate that it happened in late April and that it didn't happen in March. They could have raised those ramparts that I talked about earlier and prevented this had they gone in. And they didn't do, they were in very few homes, to be honest, but it was so symbolic. It was so powerful. I think people really understood at that point just how grave things were.
Let's do some comparing and contrasting here, because when the first wave hit a year ago, apparently 82% of COVID deaths happened in long-term care. 82% of deaths in Canada. That was twice the rate of other OECD nations. Do you know with the second wave whether or not we've got that percentage down?
Well, we've got the percentage down a little bit, but only because other people have died. It's been spread. The second wave has actually been much worse. It's been much worse for seniors, and it's been much worse for people in the general community. So we have nothing to be proud about, the fact that actually more elders have died in the second wave than the first. So we've seemingly learned no lessons. One of the most shocking things to me when I read about homes that had an outbreak in last March, had many deaths, and today they're having another outbreak and people are dying again. It's like, why didn't we learn anything in the interim?
I know it made for a good clip when he said it, and it may be the one thing that people remember Premier Doug Ford saying about long-term care. He did promise to put that so-called iron ring around long-term care and truly protect people. That promise was many, many months ago. Are we doing any better today?
Well, clearly, no, there's no iron ring because, as I said, the deaths were much higher in the second wave. What's helping people? The deaths have now come down quite dramatically, and it has largely to do with vaccination. Vaccination is having a dramatic impact. There were first people vaccinated were in homes, and that gives us some hope. But I hope we just don't forget the horrors that have happened because things are suddenly getting better.
Early on in the pandemic, and you've referenced this already, you did write the piece saying, if you've got relatives in long-term care homes, you may want to get them out if you can because this looks very desperate. What gave you, I guess, the notion that this was going to be far more of a crisis than even people who worked within the industry saw coming?
Well, I don't know that I had any more insight than anyone else, but I was just watching what was going on again in Italy and Spain. All the writing was on the wall. I think a lot of people, anyone with just even the least bit of knowledge about infectious disease, about seniors, they knew the risk. Why it wasn't talked about more openly, I'm not sure, but I certainly didn't have knowledge that anyone else didn't have. I just had the forum to be able to articulate it without worrying about the political blowback.
Well, one of the things I liked so much about your book is that you really do take us chapter and verse through many of the different elements of this story. You point at these specific things and then explain where they fell short and how we can improve them. So let's go through some of those right now. Staffing at long-term care homes. What has been the problem? What needs to happen?
Well, there's many things. I think staffing is probably the number one problem. It's where we have to start fixing things. The problem is there's just not enough time and not enough people to provide dignified care. So what's the solution? Well, we have to start having standards. So guarantee a minimum of 4 hours of hands-on care for everyone in a long-term care facility. That should be the starting point. Now, they get maybe 2 hours if they're lucky. So it's just totally inadequate care. The staff is underpaid, overworked. We know that the conditions of work are the conditions of care. If workers are treated badly, if they're badly paid, there's no way they're going to deliver good care. That's been proven time and time again around the world. So those are the fundamental things. Pay people, treat them properly, and the care will improve dramatically.
Well, that leads to the second thing, and it requires, obviously, a willingness on behalf of the population to pay people more and to spend more, which may require them to be taxed more. Do you see an appetite for any of those things out there?
I think the reality is we're paying for this. You pay it from your left pocket privately or you pay it from your right pocket publicly. So the question is about efficiency. How can we deliver the best care for the least amount of money, get the most value for money? And I think what our Medicare system tells us is it's best to do that in a collective fashion to provide care to everyone universally, and we get some benefits of scale, et cetera, and guarantees, and not paying. We pay for a lot of bureaucracy when you have private care. So I think what we have to do is find a way of extending the amount of publicly funded care. The other aspect of it is, yes, it's going to cost more money to fix this because we've neglected it for many decades. So let's not hide the fact that, yes, we have to spend more money. And the third element is we already spend a lot of money on long-term care now, and we spend it for mediocre care. So let's get more value for the money. So the money argument, I think it's important, but it's not unresolvable, and it's not an unbearable amount of money. It's a little bit more money, but spent much more wisely.
All right, as we look through the list of problems, we've talked staffing, we've talked funding, we've talked costs to families in all of this. The other thing you point out is that the state of the long-term care facilities in which many of our seniors live has been less than ideal. What can you tell us about that?
Yeah, the infrastructure is old. It's rickety, and I think it's philosophically wrong. What we should have are, if people are going to live in care, and let's not forget, yes, some people do need to live in these facilities, but we have to make sure first that only the people who need to be there are there. I think that would probably eliminate half the need for our homes in the first place. So I say in the book, we should make judicious use of a wrecking ball to get rid of a lot of these old homes. And when we replace them, can't be done overnight, but when we replace them gradually, do so with more home-like facilities. So the countries that deliver elder care well, that's what they do. The people who are institutionalized, they don't look like institutions. They look like homes, but they have caregivers on site. They have a dozen people, not 200 in a prison-like facility.
Let me just follow up on something you said there. You said half the people who are in long-term care today don't need to be there. If that's the case, why are they there?
Well, unfortunately, they're there by default because we don't provide adequate home care, because we don't have public housing that's affordable. So if you look at the reasons that people end up in long-term care, often it's pretty banal stuff. It's they can't shovel the walk anymore. They can't walk for groceries. So why aren't we hiring young people to deliver their groceries instead of putting them in a facility at $150,000 a year? So it's about spending more wisely. It's about listening to people's wants and needs. As you said at the outset, I've never met someone who said, oh boy, I'm really eager to go live in a long-term care home. No one wants to, and that fear has grown exponentially during COVID. I think, that no one, 101% of people do not want to go to long-term care now because of what they've seen.
Well, one of the things that the coronavirus crisis has certainly pointed to is the fact that if you can live safely and happily at home with some support, you should. You'll certainly be your chances of getting COVID staying home are certainly a lot smaller than they would have been had you lived in a long-term care facility for the past year. And I think I remember a statistic in your book saying something like, is it over 80% of Danes manage to have their accent on home care as opposed to institutional care? Should we be trying to do more like the Danes?
Oh, absolutely. I think Denmark is the gold standard in the world. And what distinguishes Denmark is it's a philosophy. The philosophy is our elders are valued, they matter, and we want them to live in the community as long as possible. So everything is done. They have an excellent home care system, and only the people with the most advanced forms of dementia who wander and would be in danger, only they end up in homes. And those homes are really homes. They're not institutions. So I think it begins with the philosophy of care. It begins with listening to people. To me, it's always been perverse that no one wants to go to these homes, but they're the default setting. That just doesn't make any sense to me at all. And we have to fix that, and we have to fix it quickly.
Yeah, the other thing I don't get is that the most expensive place to take care of a frail elder senior is in the hospital. The second most expensive place would be in long-term care. The cheapest place, the most effective place, would be putting supports in place so they can stay in home. And yet that seems to be the option that we are the least interested in. Why is that?
Well, it's as we talked about earlier, there's this assumption that things cost more to keep people in the community, and it's not true. We know that from other countries that the costs are comparable. And even if you are I'll be the devil's advocate, say we believe that it costs more, the easy way around that is to do like Britain. You say, well, you can spend as much on home care as it will cost us to put you in an institution. So that's $180 a day. If you gave people $180 a day for home care, overnight, we could easily remove 25% of people from care homes and then build from there. So these are solvable problems for the money we have now. And if we put a little bit more money and effort into this, we can make a big difference in the short term.
And let's just understand what home care is. When you're a frail elderly senior, but who is still able to live in your own home with some supports, what do those supports look like?
Home care is generally helping with the activities of daily living, as the jargon goes. So eating, preparing your meals if you can't do that, toileting, bathing, practical things, shoveling your walk. So just things that you would normally do that you're unable to do because you have some form of minor disability. A lot of cognitive issues, helping you remember to take your pills. These are all things that personal support workers and nurses do in the home. And doing it in the comfort of your home just makes it much easier, makes it better. The other aspect of home care, and this is something we don't do at all, that is done in other countries, is called reablement. So you don't necessarily cook for someone who can no longer cook because their eyesight is bad. You teach them different methods. Here's how to cook if you're blind. And that's what the Danes do really well. They really put a focus on independence. We're going to do everything to keep you independent as long as possible. And we don't do that. We do the opposite. We make people couch potatoes. Sit there. We're going to cook for you. You're going to lose your mobility, etc. And it's just the wrong approach for all kinds of reasons.
I would like you, if you would, to compare Quebec and Ontario, because I note that it was last summer that the government of Quebec decided that it was so important to improve home care, they were going to spend what it took in order to get 10,000 more PSWs out and available for the community. In Ontario, I guess our government made a similar decision, and they made it about a week and a half ago. What happened there?
Yeah, so Quebec and Ontario are slightly different when it comes to the base, so where we start. Quebec has a lot more government-provided care, so it's a very publicly funded system. It has way more seniors per capita in care than almost anywhere in the world, so a lot of people are institutionalized very early. Ontario has fewer people in care, but it funds a lot less, so there's a lot more private provision of care. People have to pay out of pocket a lot more. Quebec, as you noted, during the crisis announced this huge staffing push. So we're going to hire 10,000 personal support workers. A year later, they have roughly 5,000 new ones. So it's showed how it's difficult to recruit and train and keep these workers because it's really backbreaking work. But Quebec, Ontario, as you noted, hasn't really put that hiring push on. They've put more effort into building infrastructure. So they've announced, I think it's $1.8 billion for new beds. And to me, that's troubling. I think the worst thing we can do in this pandemic, and some people find this odd, but I think the worst thing we could do is actually just build more mediocre beds, because that's not what we need. We need to improve the care before we expand it.
Let me ask you as well about ownership, because the Ontario NDP, the official opposition, have made who owns the homes that these people live in a signature policy issue for them. They have said they want to nationalize all privately owned long-term care homes in the province of Ontario. Haven't quite said how they intend to fund it, but that's their plan. Do you have evidence that says that seniors do better in publicly versus privately held long-term care facilities?
I think it's a question that's not as simple as it's made out to be. So I think saying get rid of all private for-profit operators is a simplistic solution. I think you have to understand why they're there in the first place. So they're there because government won't invest in infrastructure. So that's a problem you have to solve before the ownership question. I think the question, in Ontario, it's about 60% of homes are privately for-profit homes. Changing that overnight is going to be difficult, if not impossible. I think other things have to change first. You have to get the staffing right. You have to remember that whether it's a private for-profit home, a publicly funded home, they get the exact same amount of money for care. So we have to fix that regardless of ownership. The owners make their money off the accommodation, so renting facilities to you. So to me, where I would put the priority is there are some people in this sector who are slum landlords. Let's put it honestly. We have to get rid of them. It's not all private homes that are bad. It's the ones that treat the residents as this chattel to be made money off, and they don't really care about the care. And that's a minority, but that's where the focus should be rather than an obsession with for-profit.
Okay, just as we finish up here, I want to do one more excerpt from the book, and then I'll get you to comment on it. Sheldon, if you would, let's bring this graphic up. If there's one thing Canada does better than any other country in the world, you write, it is producing reports and recommendations on how to reform its health system. Since the advent of Medicare, there have been at least 150 inquiries, parliamentary hearings, task forces, and commission reports on the sad state of long-term care, home care, and elder care, not to mention media exposés, academic work, and cris de coeur from families. And yet, very few of the recommendations ever get implemented. The result is neglect by institutional indifference, a combination of bureaucratic inertia, constant political changing of the guard, and fear of change, for which elders have paid a heavy price before and during the pandemic. André, I want to ask you about the current plans of the Ontario government. They have a task force in place right now that has been actually taking testimony from expert witnesses for many months. And they're going to write a report that's due at the end of April. And I guess, based on what I read here, what kind of expectations do you have that that report will go anywhere?
Well, I think unfortunately most reports essentially become doorstops, right? They're not useful for anything if you don't commit to implementing recommendations ahead of time. I just don't think it's useful to do inquiries anymore. So we talked at the outset, we need a reckoning, but that reckoning has to be about action. It just doesn't have to be this looking back, oh, we were horrible, a little self-flagellation, and then we move on. To me, if you're going to have an inquiry, if you're going to have a commission, you have to give it a very specific goal. For example, let's solve staffing. Tell me how to get 4 hours of care for everyone. Tell me how much it'll cost. And I commit upfront to funding that. That's how you have to do an inquiry. You can't just have this widespread, oh, tell me what went wrong, and then I'll feel bad about it for a bit and forget about it. We've done that for 50 and 60 years, and it's not working. We have to have a commitment to act.
Well, the inquiry is supposed to report later this spring, and we will see what they do. And we'll probably have you on then and talk all about it. André, I want to thank you for coming onto our program tonight. The name of your book, Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. It's always great to have you on TVO. Merci, mon ami.
Thank you, and stay well.
Tomorrow on the agenda.
We talked just briefly moments ago about social media. Obviously, given that, one tweet could mean not just character assassination, but frankly, the loss of your job, and certainly the elimination of a healthy reputation up until that point. People do worry about what's going to come out of their mouths.
That's tomorrow on the agenda. Time and again, Ontario Premier Doug Ford promised his government would put an iron ring around seniors in this province. But as the government's own Long-Term Care Commission established, residents and staff in that sector have been disproportionately affected, heartbreakingly so, during the COVID-19 emergency. With us now on why, and we'll introduce our guests, as is our custom, from furthest away to closest to our studio, starting in Waterloo, Ontario, with Peter Sean Taylor, Senior Features Editor at C2C Journal. And in Ontario's capital city, in Scarborough, Vivian Stamatopoulos, long-term care researcher with Ontario Tech University and co-founder of the advocacy group Doctors for Justice in Long-Term Care. In the St. Lawrence Market area, Donna Duncan, Chief Executive Officer of the Ontario Long-Term Care Association. And in Little Italy, Pat Armstrong, Distinguished Research Professor of Sociology at York University. And we're glad to have all four of you on our program tonight. I'm going to ask Sheldon, that's a good shot. Let's keep that four shot up because, there is an independent commission right now tasked by the province to look into the whole disaster that long-term care has been over the past year, the disproportionate impact that seniors have taken during this COVID-19 outbreak. Can I just see a show of hands? We got four experts here who know this area really well. How many of you have offered testimony to this Long-Term Care Commission? Show of hands, please. 1, 2, 3. Okay, Peter, not you. So let me find out from the other three of you. Donna, why don't you go first? How useful do you think the exercise was?
Well, we called for a commission, Steve, before it was actually struck, but it was struck, in our view, it needed to focus on actions, reflect, validate on what the root causes are, even though I think we all saw what was coming, but focus on what are the solutions and how do we move quickly to mobilize towards that. We've had lots of reviews, lots of other commissions, but for us, it was validating, and we're looking forward to seeing the recommendations, but with a focus and a bias towards action. Okay,
Vivian, a useful process in your view?
It was, and although unfortunately I didn't get a response to my request to be interviewed, I have read the transcripts, and it was very eye-opening what we learned. So there is no question of a doubt that they are helpful. What we will do with that evidence is another question. Will this government actually use it? We don't know.
Now, you said you asked to make a deputation. Do I assume then that you presented them with your findings or a report, but they didn't call you as a witness?
Effectively, I inquired to them, how do I go about providing a testimony? Because I'd like to, and I never heard back.
You never heard back?
No.
That's a bit odd, don't you think?
Yeah.
Yeah, you think so too. Okay. Pat Armstrong, how about you? Was it a useful procedure in your view?
Yes, I think that especially their early recommendations, not waiting till the end to come out with suggestions around staffing, for instance, or around inspections, I think was very useful. I also think that the testimony is very useful. When we have access to that kind of public information, it's very important, I think, in moving us ahead out of this crisis and working to make long-term care as good as it can be. And we're far from that right now, before pandemic, but especially at this period in time.
Well, let me pick up on that angle with Peter, because Peter, okay, you did not participate in this, but Pat is right. They have published the testimony of the witnesses. And this past week, we discovered some of the testimony from the Minister for Long-Term Care and for Ontario's Chief Medical Officer of Health. What did you learn from their testimony that you didn't know before?
Well, I think it's filled in some shading. I mean, we knew that there was a lot of confusion going on early when the pandemic hit. We didn't know, people in charge didn't really know how to respond. Certainly the hospitals have responded more effectively than the long-term care homes. So it gives you a sense of how the various leaders were kind of flailing around a little bit to figure out how to respond. Obviously, it had major consequences, but I think we kind of knew that story before the commission. I stand to be corrected if some of the other experts think we're learning new stuff, but it seems to me it's reinforcing the fact that there was a lot of flailing around.
Well, flailing is an interesting choice of word, and Vivian, I'll get you to comment on that. If in fact this group has demonstrated that it did too much flailing in the beginning, why should we trust them to figure this out at this stage of the game?
The government, you mean?
Indeed.
Well, we don't. I don't, personally. And that's probably the most upsetting part, and which is also why I have a separate advocacy team that is working on national standards right now, because we're very firm on the opinion that some provinces are going to be difficult in actually making the kinds of changes we need. So we're starting to put our eggs into the federal basket, so to speak.
Pat Armstrong, do you have faith that this crew can figure this out?
Well, I think they can highlight what we have known for a very long time, our problems in this sector that have been exaggerated by COVID. So I think that there are points in time where particular kinds of interventions can matter. I've personally been studying this area for 25 years, saying many of the similar things, but maybe we're at a turning point. Maybe we're at a place where it can make a difference. For instance, around the 4 hours minimum of worked hours for care, we've been arguing for that for a long time. And in fact, those numbers are outdated. But if we could do that immediately rather than planning for it over 4 years, as we've heard, then I could think it could make a huge difference.
Well, they've said they're not going to do it immediately, that they will do it over a longer period of time. So what do we conclude from that?
Well, I'm worried about that. I'm also worried that the vaccinations are already dramatically reducing the death rate. So we'll say, oh, that's yesterday's problem. We can move on to something else. But we have to fix this now. We've had many opportunities, as we've already heard. And as the Royal Society report said, we've studied and studied and studied. It's time to act on it now.
Well, let me put that to Donna, because our previous guest, André Picard, did point out in his book that I think he added them all up. If you take parliamentary inquiries, task forces, royal commissions, committee reports, and so on, he's got it up to 150. And he says almost all of them have made great doorstops, but they haven't really been acted upon. Do you have any reason to believe that this one will be different?
Well, Steve, to Pat's point, I think this government has committed to increasing that to 4 hours of care. That's progress. We've got to hold them accountable to making sure that happens. And the sooner the better. I agree. We need to move quickly on that. Progress on the 3 and 4 bedrooms and moving capital along. In our data and our analysis, one of the most shocking findings that we actually saw was going to compromise the health and well-being of our residents to tragic consequences was the impact of 3 and 4 bedrooms and those old homes. And we'll give this government credit for starting to move on that, because it takes 3 to 5 years to rebuild. We know that we're not going to build enough. We've got to look at a full system of care. And I believe that it's going to take all of us working together to problem solve. And I'm not going to look just to government to actually find the solutions. I think we can develop solutions with them and drive government to actually deliver on them. But waiting for government to solve the problem, all of those reports are there. Let's build our own bound on ourselves, and let's celebrate incrementalism and move this forward as quickly as possible. We've got to meet that baby boom bomb that's about to hit.
Vivian, our director took a cutaway of you during the midst of that answer, and you had a bit of a skeptical look on your face. Do I infer correctly from that?
Yes, you do, because we know that even for accounting for facility design and chain ownership and community transmission, the Toronto Star just published data for the last year in total. And all of those factors aside do not count for the fact that for-profit homes still have many more deaths. I mean, the difference is significant. So 7.3 deaths, COVID-19 deaths per every 100 beds for the for-profit sector, all the way down to only 1.5 for the municipal sector, right? And I want to remind everyone that this government, Ontario, and this started with Mike Harris, have increased the capital development funds for homes to rebuild and upgrade 4 times now over the past 2 decades. And while many homes did do just that, for some reason, the for-profit homes didn't decide to. So why are they going to do so now?
Well, as long as you bring these numbers up, I was going to get to this later, but we may as well do this now. Sheldon, middle of page 2, let's talk about this private versus public ownership situation. We got more than 600 long-term care homes in the province of Ontario, and here's how they break down. 360 are for-profit, 162 are not-for-profit, and 101 are run by municipalities around the province of Ontario. Let's continue, and this one will speak to age. We have a lot of homes that are designed and built before 1972, so they are coming up on a half a century old. More than half of for-profit homes are coming up on 50 years old. More than a quarter of not-for-profit homes were designed and built before 1972, and just over 10% of municipal long-term care homes are coming up on 50 years of age. Okay, Pat, tell me about the significance of the Let's go to that second set of stats first of all. The significance of the fact that we have a lot of stock out there right now that is coming up on a half a century of age. Why is that important?
Well, it is important to get rid of the 4-bedrooms for sure. But as Vivian pointed out, that there's been money there to do that for quite a while, and it hasn't been done. I think we do have a long series of studies that indicate a pattern of lower quality care in the for-profit homes, and certainly of lower staffing levels and lower pay and more part-time staff in at those for-profit homes. So when we're talking about a pattern, of course, we're not saying all for-profit homes are horrible or all municipal homes are wonderful, but we do have a pattern, which is what we always look for in research, just like we do in terms of the vaccines are only 80% effective. They're not 100%. It's not about 100% of the homes, but we do have a pattern. And I don't think anyone's saying tomorrow morning, get up and get rid of all of the for-profit homes, but that we should work in that direction. And we should also work in that direction in terms of, I would argue, contracting out the services within homes, because we have similar kinds of evidence there as well.
Peter, why haven't those investments been made over the years?
Well, I'd like to talk to Vivian's point first, perhaps, that it's self-evident that for-profit homes are delivering poorer care. It's not the case. I wouldn't take the Toronto Star as my objective source of truth on this. They planted their flag as soon as the pandemic started. It's been a nonstop series.
Okay, Peter, hang on. Just let me just say for a second that all the numbers we just gave are not from the Star. I'm going to give the Star numbers in a second, because they did do a deep dive this past weekend. But all those numbers are from Nathan Stahl, CMAJ journal numbers. So that's just to correct the record.
Sure. So let's use those figures. And that figure found that there was no statistical significance to being a for-profit nursing home. The factors that explained why there were outbreaks were the size of the outbreak in the region surrounding the home, the age of the home, and the number of residents in the home. So if you read that Canadian Medical Journal article, you'll find that the for-profit isn't a factor. So let's put that on the table to start with. so going forward, what do we want? We want the best possible situation for seniors. We should be taking all the recommendations that are out there. I haven't seen any recommendations from, for instance, the National Institute on Aging just came out with a series of recommendations on how to improve things. They don't talk about ownership, they talk about regulation. So I think for-profit and nonprofit can both benefit from new regulations.
Okay, Vivian, let me just, I'll basically sum all this up and then I'll get you to comment on it, because that Canadian Medical Association Journal study suggests that there is a statistical insignificance between profit and not-for-profit when it comes to safety of residents. That's the conclusion they came to. You're disputing that?
Absolutely, I am. There are many problems with that paper, and I've talked to Nathan directly about it. But furthermore, it's a bait and switch argument here. So what we're seeing is that the advocates reading the first part of the paper and ignoring the rest, right? So they don't pay attention to the fact that community transmission apparently, and this was only up to wave 1. So subsequent data the Toronto Star found that has been concurred by other epidemiologists, very well-known ones, have agreed that that finding is there, that ownership does matter. So that aside, it only looked up to wave 1. And there's a little bit of an ecological fallacy because you don't know if the workers actually work in the areas of the community transmission that they looked at. But that aside, it's still found that once the virus gets into the home, and this is what matters the most, how do the for-profits handle it? And the rest of that paper outlines in black and white that they fail to control that outbreak. And that's what matters. Getting one outbreak, getting one case, that's an outbreak, is not the issue. It's how you manage it once it gets into the home. And they can't. They've had the deadliest outbreaks and the highest mortalities. And even the Stahl paper found that. So
can I just follow up with you on that?
paper.
Let me just follow up with you on that. We know there have been outbreaks in lots of long-term care homes across the province. Once the outbreak hits, why would, in your view, the level of care in for-profit settings be any different from in not-for-profit settings?
Well, I'll tell you why, because it boils down to staffing. And that's also something that the Stahl paper didn't have. They don't have information on staffing because this sector refuses to publicly make that information available. Correction, the for-profit sector refuses to make that information publicly available. So we know, frankly, that ownership matters when it comes to staffing. Staffing matters when it comes to managing outbreaks. It is irrefutable that the for-profit homes hire less staff. They hire less full-time permanent staff. They pay their staff less, and they produce less hours of direct care per day. And you know why? You know how that impacts to resident care and the COVID outbreak? Because this is what happened. When the April 22nd directive came limiting employment to one home, what do you think happened? The workers at the for-profit homes left. They left for greener pastures. They left for places that paid them better and had better working conditions, period. And that was corroborated all throughout the testimony in various different testimony transcripts in the commission. So we know that. And then we saw in black and white, all of us saw this in real time, in addition to the testimonies, that what happened was that many of the for-profit homes were in a mad dash to find workers. Oftentimes, they threw workers without proper training onto the floor in the worst time, possibly, period. And what happened was negligible infection prevention and control mistakes were made that led directly to resident deaths. I mean, this is a very clear causal chain here. I mean, we have evidence, Sunnycrest, Tender Care, Roberta Place, in ministry inspectors' reports showing clear negligence that resulted in increased death.
Okay,
we have leaked paramedic reports from St. George.
I hear you. Let me give Donna Duncan a chance to respond. Lots of stuff to respond to there. Donna, go ahead.
Yeah, certainly. And, we're going to agree to disagree with Dr. Vivian insofar as, our for-profit homes, our nonprofit homes, everybody struggled in this. As André Picard said, this wasn't a fair fight for anyone. If we look at the ownership of homes, the larger chains and private homes largely are for-profit homes because the nonprofit and charitable homes were rebuilt during the Harris government in 2000. The last time we had any significant movement, we have members of all ownerships who have made multiple applications to rebuild these homes over the last 20 years, and it hasn't happened. And
why not?
Yes.
Why has it not happened?
If we look back to 2007, when the Liberal government of the day made an announcement and a commitment to two things: aging in place and rebuilding these older homes. They moved forward in aging in place, but they didn't move forward on these homes, and we are seeing the consequences of that, and we need to move quickly. And I think the other thing I would say that And just to echo André Picard, we're getting caught in a divisive, polarizing debate around ownership. We don't have the luxury of time for this. This is a very emotional debate. I know, I feel it. We've had tragic loss. But quite honestly, we need to mobilize to work towards solutions, to find our way through. We need to build a workforce. We need to work to build out that forest care. We need to rebuild these homes, and we need to find a way to rebuild confidence, rebuild the morale and the mental health and well-being of our residents. Because I don't think it's an overstatement to say that all of this fighting and this polarized activity is having devastating consequences on our existing workforce. And as much as our government has tried to attract people in, money's not going to help. Morale's going to help. And how we talk about this workforce and how we support the workforce and focus on the people who are living in these homes and working in these homes, we're not going to make sure, we're not going to have a system that's going to be able to support the care.
All right, let me get Pat Armstrong on this. Pat, do you believe that there is a difference in the quality of care and in the ability to fight COVID-19 between for-profit and not-for-profit long-term care homes?
Yes, I think we have considerable evidence to indicate that. Do I think it's the only factor right now? No, it's certainly not, but it's certainly a factor, I think, from all of the evidence we've had. And as I said earlier, we had evidence pre-COVID of more hospital transfers, more bed ulcers, higher mortality, for instance, in for-profit homes, a clear pattern. So, and the staffing levels, as Vivian pointed out, are absolutely critical. And not just the staffing levels, but the proportion of staff that's part-time. And that's true across all of the homes, but we know that that proportion is higher in the for-profit homes. We do have to increase the full-time staffing across the board in all of the homes. It's absolutely critical. We do have to make regular training available to all of those people in the home. That's not to say people aren't skilled there now, but all of us have to constantly upgrade our skills. I do. I have to keep reading as I teach. That we have to keep training. We have to keep providing people with the kinds of supplies they need in terms of long-term care. So there are a lot of strategies we have to follow it. Addressing the for-profit one is just one of those strategies, but I think it is a strategy we need to follow. Okay,
well, I think Vivian referenced the fact that the Toronto Star came out with a really lengthy article, a series of articles actually on this past weekend. And Sheldon, I'm at the top of page 4 now. Maybe you could bring up that first graphic on the top of page 4. Because the Star, now this is a complicated looking graphic, and for those who are listening on podcast, I'm going to go into just a little bit of detail here and explain what we're seeing. We're looking at COVID deaths in for-profit long-term care homes. This is as of the 22nd of February of this year. And the Star found an average of 7.3 deaths per 100 beds in the for-profit situation, 7.3. They compared it to 3.8 average deaths per 100 beds in nonprofit homes, and only 1.5 average deaths per 100 beds in municipally run homes. So their conclusion is, and Peter, I'll get you to comment on this first, their conclusion is the for-profits didn't do nearly as well as the not-for-profits or the municipals. What would you react as far as that study is concerned?
The Toronto Star has had that conclusion since the very beginning, regardless of the evidence. The little charts there with the little bubbles, that's not as sophisticated an analysis as the Nathan Stahl piece in the Canadian Medical Journal, which ran everything through and found, to repeat myself, the findings of that study, peer-reviewed, using advanced statistical methods, is that for-profit was not a significant factor. It was the community, the size of the community outbreak, the age of the building, and the size of the building. And to Vivian's point about how there's been more deaths in the long-term, in the for-profit long-term cares, it's because they're running bigger buildings that were built to older standards, and that's what the finding is, and that seems perfectly logical to me. That the 4-bed ward is being identified as one of the most significant factors in this whole thing. And the fact that the for-profits have more 4-ward beds simply reflects the fact that the for-profit sector has been there for the province for a lot longer than the nonprofit or municipals. They were the ones delivering this service for decades.
All right, let me ask the follow-up question then, Peter. The follow-up question is, what would happen if the province of Ontario made the decision to to completely get out of the business of allowing for-profit long-term care homes in the province?
It's completely impractical. Already they're providing almost 60% of all beds across the country. For-profit provision of long-term care is the dominant model. It's 37% across the country. So you simply can't survive without the for-profit, without the private sector involvement in this. It is absolutely essential. And if you remove it, you're going to spend hundreds of billions of dollars compensating, and you're going to spend money that does nothing to improve the situation. All you're going to be doing is paying private sector to turn things into nonprofit with no gain there. You're not going to add anything to the capacity of the province or the country. And we know that we're going to need substantially more beds in the future. Where are those beds going to come from? It's going to be the private sector.
Your view on this is clear. I want to hear from Vivian and then Pat on this same question. If the province decided to outlaw for-profit long-term care homes in the province of Ontario, what would be the impact of that? Vivian, you first, please.
First of all, we're not asking for that. And this is an argument that has been embedded by the for-profit individuals. Nobody is saying to buy up all the homes. Nobody has ever said that. That is a fear tactic.
Vivian, the NDP is arguing for it.
They're saying in time. What they are saying is that when the contracts come up for expiration, which some of them do at varying different times, so this is not something that would happen tomorrow. They're saying when those contracts come up for expiry, don't renew them. Don't renew them because the evidence doesn't support that you should. We have glaring evidence against for-profit. It's anti-evidence if we continue along this dysfunctional status quo that we saw firsthand led to the worst mass casualty event in our collective long-term care history. It is frankly offensive to try to say that this is a divisive strategy to pit people against one another when frankly, this is the workers speaking up. The workers felt betrayed by these for-profit companies. The residents felt betrayed. The public feels betrayed. This isn't a few of us that feel betrayed in academia. No, this is the public. And I just want to remind people that 86% of Canadians were recently polled and said that they want long-term care within the Canada Health Act and operated not unlike hospitals because they saw that hospitals were prioritized and long-term care wasn't.
But if they knew, I appreciate that survey, but if they knew, and I'm just asking here, I'm not trying to advance a view here, but if they knew that it would cost tens of billions of dollars to repatriate those currently privately owned long-term care homes into the public Medicare system, would they still be as in favor of it, do you think?
Yes, I do think so. And frankly, we pay for it regardless. So let's not act like the for-profit sector is giving us a gift. They're not. In fact, we are helping them to secure real estate investments across Canada. We are making them very wealthy in the process. So let's not pretend it's a present. We can give this to individuals who actually operate more ethically and follow clear evidence that suggests if you do this and you have certain staffing policies, we know it leads to better resident care. But instead, we have a for-profit sector that uses a business model that tries to skim off the top. And while they're doing that, they're doling out tens of millions of dollars every month to their shareholders while residents die in neglect.
Okay, Pat Armstrong, let's hear from you on this issue.
Well, first of all, I would say that the article written by Stahl and others was the first wave, and the data that you just showed is second wave. So there are different issues coming up here. And I'm really surprised at the notion that the not-for-profits and municipals don't have old homes. I've been in all of the Toronto homes, and I can tell you quite a few of them are old still, although they're moving significantly towards improvement. But I don't really think that we need to get bogged down in using one article as our evidence for what's happening here. And nobody's arguing that tomorrow morning we're going to take over all of the for-profit homes. I think the argument is, given the evidence, we should move in that direction. And I think it's also a question of to whom are they responsible on a regular basis. And, for-profits have a responsibility to make a profit. That's the point. So it's not to say these are mean or awful people, but that is what you need to do, and that means that money is not going to care. And when we're talking about what's the advantage of having a for-profit home, it's not in terms of cost, because we pay the same amount of money. It's not in terms of choice, because we have 38,000 people waiting for a home, and so they're not getting a lot of choice. And the other argument is the capital. But as Vivian just said, we pay for it in the long run, and we pay more for it if it was our capital going in. But of course, we can't do this overnight. That we can't take over.
No, I understand.
60% of the homes.
I understand. I've got a minute left here, and Don, I'm going to give it to you and let's just put the scenario out there. If the NDP wins the next Ontario election, their view is we're going to nationalize all currently privately held long-term care homes in the province of Ontario. You will meet with the new Minister of Health under those circumstances, and you would tell him or her what?
Well, I'm going to say it's going to be like auto insurance under the Ray days, where they made a commitment to make auto insurance public, and they couldn't do it. It's astronomically expensive. It's not the problem we need to solve. I've been meeting with my global partners throughout the pandemic since last January. This is a global pandemic we're in. This is a global issue around staffing. It's a global issue around the buildings. And I think we do need to have a bigger discussion about what is long-term care and how do we take it out of a cookie cutter box? How do we stop personalizing this as an issue and make it about the people and the population we need to be able to serve, whether that's new models of care that are closer to the acute care or subacute continuum versus housing? How do we support people from independence into care in a very respectful, person-centered way and make this about our seniors and deal with the ageism and focus on those problems, not on actually doing something that will profoundly destabilize the economy and destabilize the sector just as the baby boom bomb is about to explode.
I know this is a tough and controversial issue, but I do want to thank the four of you for coming on to TVO tonight and having such an energetic and engaged and yet civilized discussion about this whole thing. Peter Sean Taylor, Pat Armstrong, Donna Duncan, Vivian Stamatopoulos. Really great to have you all aboard tonight. Take care, everybody.
It was a pleasure.
Thank you, Steve.
And that is the agenda for Wednesday, March the 3rd, 2021. How much free speech is enough in a democratic society such as ours? Tomorrow, as part of our joint TVO Toronto Star initiative, The Democracy Agenda, we'll debate that. Also, former leader of the Federal Liberal Party, Michael Ignatieff, joins us on why the Liberal Democratic tradition should not be timid in its own defense. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.